Good afternoon, everyone, and many thanks for the invitation to speak today on a central issue of billing and coding with electronic health records. Let me tell you a little bit about AHC. We represent nearly 100 academic health centers nationwide, and we're dedicated to improving the nation's health and well-being by mobilizing and enhancing the strengths and resources of the academic health center enterprise in health professions education, biomedical and clinical research, and patient care through their associated hospitals and health systems. We have the privilege of not being discipline specific in that we represent all the components of the academic health center, including all the multiple schools such as medicine, nursing, pharmacy, allied health, veterinary medicine, whatever happens to be on a particular campus. I want to talk about the billing and coding situation at a very high level today. I really only have 3 points that I would like to make. First, and perhaps most importantly, we believe that the fundamental problem in this area is that many of the billing and coding regulations are rooted in the past. What is needed in our view is a system of regulations that matches both the current and the evolving environment. So we see a real disconnect there. That's a fundamental challenge and very much a fundamental problem. I will also address the need for increased clarity, and I think you've probably heard about this during the course of the day, in coding guidelines, particularly in inpatient settings for evaluation and management services, or E&M. And finally, I would just like to point out the significant ongoing investment that the nation's academic health centers have made and are making in their compliance programs. I think we all agree that electronic health records clearly have great potential to increase patient safety, quality of care, and efficiency. I don't think anyone would necessarily argue that. And they're crucial to enable health professionals to deliver patient care, especially, I think, the patient care of the future. But changing demographics, increased coverage due to the Affordable Care Act, and evolving payment models and clinical experiments, along with a myriad of technological advances, are all contributing to what we would describe as a time of disruptive innovation in the way healthcare is delivered. To meet the needs of their patients, health professionals will need to be able, for example, to work effectively in interdisciplinary and interprofessional teams, practice at the very top of their scopes and capabilities, and in doing all this, work seamlessly with electronic health records and other available technological tools. AHC and its member institutions acknowledge that while electronic health records offer a great opportunity, they certainly pose potential problems. You know, we were one of a handful of organizations that opened up the mail on a Friday a while ago and received a letter, I think it was in September, from HHA Secretary Sebelius and Attorney General Holder. The letter expressed concern about observed trends that might indicate that electronic health records are being used to perpetrate fraud. The trends mentioned in the letter were particularly related to the coding of evaluation and management services and indicated an intention to have CMS recovery audit contractors, known as RACs, focus more heavily on E&M billing and coding. Now, the theory that electronic health record templates for clinical note documentation inherently lead to upcoding is far from proven. In fact, there is some evidence to the contrary. In a December 2012 article in the New England Journal of Medicine, the point was made that trends in higher E&M codes in emergency rooms were actually linked to shifts in patient demographics and a changing care delivery environment. Templates do serve as helpful prompts and guides to remind healthcare providers to document information that may not previously been written down or dictated into a note. One of the goals of increasing the use of EHRs was to increase the accuracy of documentation. The use of a template to encourage this increased accuracy does not deserve to automatically be flagged as fraud and trigger a RAC audit. While we agree that some EHR features have the potential for misuse, Academic health centers have and will continue to foster a culture of compliance and impose consequences whenever necessary. Over the past several years, our member institutions have worked diligently to develop robust compliance and auditing functions in order to prevent and, if necessary, respond to instances of fraud, waste, and abuse. Indeed, a survey that we did of our members a number of years ago demonstrated in place the comprehensive and costly nature of these efforts. Chief compliance officers from our member institutions participate in AAHC's Forum on Regulation, where they have worked for some time to share best practices. In the past few years, the group has expressed concern about the availability of clear and useful guidance on the coding and evaluation and management services. And in AHC's response to the September letter from HHS and DOJ, we continued to again express these concerns. AHC believes the crux of the problem lies in a system attempting to adjust to the future while still being rooted in the past. Current billing and coding regulations reflect a practice environment that is on its way to extinction. An environment in which healthcare providers do their charts by hand, we can all think about Marcus Welby, and keep paper records while serving a younger patient population with fewer comorbidities. For example, current documentation and payment guidelines for E&M services require inclusion of certain data points, for example, social history, past medical history, family history, in the note itself to justify a higher coding level. However, electronic health records are structured to allow for the storage of these data points without including them in the note itself. Omitting one or more of these data points from the note could lead to a significant financial penalty, even though the information was appropriately obtained by the provider. We strongly believe that billing and coding regulations need to be updated to reflect the changing demographics of the patient population and the rapidly evolving practice environment of the future. A future where multiple providers are collaborating with one another on a patient's care, and increasing amounts of data on the patient are digital. EHRs are designed to enhance care coordination and communication by allowing multiple providers to document the care of patient in a single note. This type of collaborative documentation can reduce duplication, decrease unnecessary errors, and streamline the process of caring for ailing patients and supporting their caregivers. The result not only increases efficiency, but also improves the quality of care being provided. Unfortunately, in professional fee billing, a single note is required for each billing provider, and those single notes must include the same items collected and already stored by other providers. I believe that this example highlights the disparity between the regulations and the way care actually needs to be delivered. AHC and its Forum on Regulation appreciate your willingness to explore and revise existing policies to better reflect the use of electronic health records. We would be most pleased to work with CMS and ONC to improve the available guidance and increase clarity for our members and the healthcare delivery system as a whole. Again, I thank you for the opportunity to speak today and look forward to working with you on this important issue in the future.